What is the gift for the audience?
By the way, for the people who will last to the end, there will be, a car gift. It's a Mercedes, but it's this size, by the way. So,
So thank you again for giving me this chance. This is a very interesting topic, and I think it's, we'll go over some of the findings and also some of the interesting new ideas that are coming out. So presenting and starting with this 28 years old, I actually referred to our institute for a congestive heart failure, cardiomyopathy, for heart failure, heart transplant, CRT therapy. She's been complaining of shortness of breath and initiated the workup. This is her transthoracic echo. You can see how bad globular her LV and the breast function. And from our assessment in the echo, looking at more detailed echo, you can start to see there's abnormal flowing from the aorta and also the abdominal Doppler blunted and diastolic drag. We took her to the cath lab after assessment of CT. You can see this is a lady, 27, referred for cardiomyopathy, heart transplant, and found to have this tight coarctation. So from anatomy, coarctation from Latin word, which is known, I will try to pronounce it, coarctatio, which is basically drawing things together very tight. It's like the diagram presented here. It is one of the commonest congenital heart disease. It has a high genetic association, up to 30% with Turner syndrome. And from a female perspective, if she has coarctation, the offspring will have a higher chance of having coarctation. One of the most important things when they present with the symptoms, whether from neonate to hypertension, we just need to, from our cardiology point of view, the age, size of patient, location, morphology, associated lesion, and whether this is a native or recurrent. This is always going to be keeping in our mind as an assessment in our back of mind when we see these patients. The age, the size of the patient, location, morphology, associated lesion, or whether it's a recurrent or native. One of the most important things in the data that came from Boston, looking at a long, many years of follow-up, is basically, which is important also from our adult colleague, is the presence of bicuspid aortic valve. So this is basically an association or a link between both of them. When they present, there is an LV hypertrophy, decreased LV compliance, there is increased myocardial mass and stress, in addition to increased LV diastolic pressure, and subsequently left-sided failure. My colleague, while did have a nice review article about it, but basically most important, as I mentioned, whether it's a native, which is most of the presentation when they come similar to our patient, usually whether they come in with a hypertension or leg pain or congestive heart failure. Assessment, ECG, X-rays. Unfortunately we don't see them anymore because of the advance in medicine, but you can tell the rib notching, which is a classic in our literatures, and you can see them here. It's because of the collaterals. There are 3 circuit collaterals that can appear with the coarctation for long standing, and one of them is these finding the bronchial arteries. Hutley is actually one of the earlier persons for non-invasive assessment regarding echo. This is her famous paper when she was in Norway in 1985 that described the Doppler ultrasound as a tool of assessment of presence of coarctation. So similar to this patient is basically a Doppler assessment and a continuous, and you see how that tight coarctation is present. Magnetic imaging resonance has been available and a very important tool in the assessment of coarctation. So moving forward, now we are aware, we have a patient, we have a diagnosis, we have the tools to assess, moving in what to do with these patients. It is coarctation as a surgical approach was the first surgical operative techniques that has been introduced in surgery. Crawford had repaired 2 patients. That's in 1945. Subsequently, there are many surgical techniques had been described, resection into anastomosis or with extended into anastomosis, which is the most common, especially in neonates and children. Later on, in older patients, patch, subclavian flap, or interposition graft has been introduced for older patient and adult patient. and this has some of the adverse outcome that need to be monitored and watched. I will share with you some of these findings. So initially, from a coarctation perspective, the initial management were by ballooning. That was described early in 72. Subsequently, 81 was the first successful angioplasty was performed and was being reported in 82. Problem is basically the advantages of a ballooning is, of course, less invasive compared to surgery, less transfusion, less hospitalization, and you can get a decent balloon and improvement. Dr. Mohammed Eid Fawzi, in his famous long-term 22 years, up to 22 years, showed that balloon is actually an effective way of modality of a treatment for these patients and adult patients. Not only that, but also when I was in Kim Hensel, we looked at actually the hypertension medication on these patients on a long term, 18 years, and it showed actually an effectiveness in relieving and decreasing the need of medication. Not only that, but also affecting the improvement in the gradient and also in the LV mass. Unfortunately, the balloon angioplasty did not really provide the excellent when we compare it to the surgical outcome. If you look at it, there is a problem with residual complication, aneurysm rupture, and some of these patients that we've took, and some of our guys have seen some of these patients, when you do a balloon dilatation subsequently later on, especially when they cross the age of 40, 50, when they have this aortopathy and the plaque formation, the wall does not support as used to be, and this aneurysm may get bigger and bigger. So this is one of the things that need to be treated and addressed by a stent. Stent and covered stent came into our practice, built as a good way of treating this lesion. Has many types of stents. Some of them are labeled here. One of the challenges of the stent is actually the diameter that can be achieved with these stents, whether they can be achieved to an adult age, and subsequently you can redilate them if you put them in younger patient. Not only that, but also if you deal with a dissection on aneurysm, whether they will be a covered type of a stent or not. These patients will require to have a longer sheath. You need to be careful with the vascular access, similar to what we saw earlier in the morning, whether you will have an occlusion device available. That will be actually very handy and very helpful to minimize and lessen the time in the cath lab. Not only that, with the balloon and stenting, also available of different balloon techniques that helped in our management and approaching to this patient and lessen the issues with the stent mobilization or stent problem. The bib balloon or balloon in balloon has provided that excellence in positioning of the stent while you doing it, in addition to having a pacing technique. Some of the problem with the stent, of course, migration, rupture of the wall, and dissection. We have a patient here, an example that I took care when I was a fellow, a patient who has a long segment. We put a bare stent, not covered, and subsequently you start to see this blip over here and more over here and here, and subsequently we had availability of intravascular ultrasound. You started with the level A here. There is not much, but when we go to level B, you start to see the space. This is a peripheral vascular ultrasound. It's an 8-French system. It goes over 3-5 wire, and you start to see how this sort of like disruption of the wall beyond the stent, and actually also even more further, and this need to be addressed with the covered stent. So not only that, this is a patient, just to go over scenario. So patient comes in, has this coarctation. You do the balloon dilatation, nicely balloon dilatation, inflation. The waist didn't appear until about maybe 75% of the balloon has been inflated. But unfortunately, the wall of this patient did not hold off. You see, it started small dissection. So you keep in mind, older patient aorta is different from a baby or a child aorta. So this is, keep it in mind. This is when you have a catheter lab with all of the tools available. This patient has a covered stent. We placed it immediately in the same setting and resolved. Another share from Dr. Wa'il experience and a problem with the graft. We mentioned one of the options that you have available for these older patient, a graft or interposed graft, problem that they do have some complication where their suture line get aneurysmal dilatation. So this is warranted a follow-up and need to be addressed, and it was addressed by a graft stent. From all of this perspective of stenting, the CCI SC, which is a group of Christiania that looked at the interventional group for coarctation from stenting, looked at it, and from this gold standard or the beautiful paper that been written looking at almost 302 patients, came the approval of stenting, of coarctation for such a patient. So this is, again, looking at my previous talk, is having the collaborative and looking at all of these literatures and outcome and, registries helps a lot in providing such paper and such recommendation. So looking at the outcome and out data and how they improve dramatically from discharge and the long-term follow-up. Subsequently, the American College of Cardiology and the AHA guidelines in 2008 mentioned about the surgical repair, but look, the new changes here is having the cath-based intervention as in hand to a surgery. Not I'm saying replacing surgery, but the option of therapy or treatment is available for patient as a cath-based when the anatomy is feasible. Not only that, but also even the European guidelines in 2020, mainly the cath intervention is actually becoming more of the lead assessment or management in these patients. Technical consideration, stage approach, light sedation for these patients. Sometimes you need to unmask the borderline gradient. For that patient, for example, that I presented early, this is a very tight coarctation. I'm not going to be able to stent that even with a covered stent and bring the diameter to a normal diameter like the descending aorta. So what we did with this patient is basically initially we did the covered stent inflation, and you start to see the waist and the dumbbell appearance, and I stopped from further procedure, have the stent anchored very nicely, and then we did the angiogram. This is just the collaterals that we have seen and observed from before. Nice interposing of the stent. There is still mild residual gradient there. We left it. We brought the patient a year later, redilated it to approximate it, and have almost eliminated the gradient. So, as I mentioned, with these patients in type 1, you need to bring them in a stepwise approach rather than to open the dilated or open the gradient. So this is what we started with, a little bit improvement, and almost normalized the Doppler. Some of the assessment tools, you have a metal, you have a frame that it's in the aorta, or even a Gore-Tex material interposed. Problem is assessment by echo. You go and put the echo, you will have a gradient of 30 or 40. If the patient is not symptomatic, what to do? This is a paper that came with echo evaluation and actually developed a formula that can be interplayed in your echo assessment and basically will give you a hunch whether that gradient is significant enough to go and warrant him and take him to the cath lab. Not only that, but also the MRI. The MRI with the 4D assessment tool is actually looked at the flow assessment across the aorta, both the ascending and descending, and actually give you a very nice flow. This is all software applications that can be applied in your MRI tool. One of the most important things, and I will leave maybe some of the thoughts here at the end, is when we say surgical or cath. I always tell my patient, I always tell my fellow, if you have a diseased aorta, whether you do surgery, whether you do cath, that aorta is a disease. So it's not going to be normal. Looking at this MRI data, which quantification, you see this is a normal. A patient who has a diseased aorta by surgery, almost completely opened, but you can tell the propagation of impulse by MRI is abnormal. Patient who has a stent from a previous surgery, still, even a lumen is open, has a problem with propagation. They even did on an animal study, a stented in a normal aorta. When you have a frame and metal in that aorta, the propagation did not have a problem with it. What does it tell you? There is a problem, it did have a problem with the propagation. So it will tell you there is a metal or if there is an interposition into the aorta, it will affect your tool. But this is an MRI assessment tool. So in summary, this is a very nicely guideline that has been published. You can see a patient comes to you, is they have an arterial hypertension with a coarctation or recoarctation, no. You will assess with the peak-to-peak gradient, no. And if there is no narrowing of the aorta more than 50% by assessment of CT or MRI, you just continue observation. And if you have a gradient peak-to-peak, may need an intervention, this is the class indication. And subsequently, you will follow this schematic, roughly diagram. That very, very helpful. And you actually basically make your follow-up assessment is easy. Not only that, but also with the stage approach that the AHA-ACC guide, whether stage A or stage D of a presentation, it make your assessment tool as an outpatient is very helpful. So a patient who has almost no symptoms, you can space out their follow-up up to 2 to 3 years. But when you have a patient with symptoms, since the one I described here, basically you bring them in more of a closer follow-up. Thank you very much.